to tell you that this is one of probably the most exciting things that I've done since I started Survivor Corps. We have the most incredible guest with us today on the most unbelievable day and time, given President Trump's press conference that just wrapped up about 15 minutes ago, talking about convalescent plasma. It's the end of July. I would like to say on behalf of Survivor Corps that we have been pushing convalescent plasma since March 24th. We've been ahead of the curve, and we are one of the strongest forces behind plasma donation in this country. We are going to do a deep dive on plasma today, and we've received so many amazing questions from you all. As you all know, I have donated my full 8 times, my AB positive universal donor plasma. I've maxed out, I reached the winner's circle. I've donated my blood for numerous vaccine trials. I'm enrolled in every study I come across. I beg and plead for every single one of you to do the same. Please go to survivorcorps.com at the end of this and see how you can sign up, find a plasma donation center near you, and sign up for trials. On that, I'm going to hand the floor over to Dr. Mike Joyner from the Mayo Clinic, who is really just about the greatest expert on plasma we could ask for. So Dr. Joyner, please, if you could introduce yourself and give a little bit of background, and then we have some questions submitted. Great. That we can start going through.
Donna, yeah, I'm Mike Joyner. I'm a physiologist and anesthesiologist at the Mayo Clinic, and I'm the principal investigator of the United States Expanded Access Program for Convalescent Plasma that your group has been so helpful in supporting through your donations, awareness, and just kind of networking. And today we've transfused at least 50,000 patients with COVID-19. We have the big announcement at the White House. We're looking forward in the near future to present some data on efficacy. We've demonstrated safety of the product and so forth. And so it's great to be here with you today and really to thank the folks in your network for their participation, their support, and again, donating and volunteering. And I hope when this is all over and we come back to kind of a normal world or normal time, that people take the opportunity to continue to participate as either blood donors or as volunteers in biomedical research, because we really need our patients to help the research and help the effort so we can make even more progress.
Well, I have to say on a personal level, donating plasma, as everyone in this group has heard me say 1,000 times over, has been one of the most gratifying experiences of my entire life, and I include getting married and having children in that. Every donation can save 3 to 4 lives. Each donation for me took 28 minutes from beginning to end, was painless, and as you've seen, I've live streamed them for you all. You could see the ear-to-ear grin on my face the entire time, and we see it in all of your donor selfies that you are posting all day long. So keep on donating, and not just once. Donate as many times as you are able. And our goal is to really truly not leave a single survivor behind. On that note, we have a lot of questions for you. So let's
go far away, Diana.
Okay, so generally, can you just tell us about how plasma treatment works? We know there's directed patient plasma, there's this new hyperimmune globulin product. Can you explain the difference and just explain to everybody?
So it's really an amazing story. So the first Nobel Prize in medicine was given to a man named Emil von Behring.
1901.
Yeah, 1901. He used horse serum, antibodies in horse serum to treat diphtheria, and it was a remarkable cure of what was a fatal disease at the time. And really, this is called passive immunity, where you take antibodies, preformed antibodies, and they can come from animals, they can come from other humans, and more recently from biotech. You take those antibodies and you give them to either prevent or treat disease. We're currently in the treat disease mode, but there are some studies going on in terms of the prevent disease mode. And the older folks, or maybe some other people in the group today, will remember getting a gamma globulin shot if you've been exposed to hepatitis. There's probably people, some of the women who've had kids who've had RhoGAM shots. Rabies treatment is again convalescent plasma or hyperimmune plasma or what you would call intramuscular IG.
Thank you, everyone, for your patience. Welcome to 2020.
Really?
Nothing is quite going as planned this year. So
yeah, I'm with LeBron James, who said, "Can we just start it over?"
Oh my God, could we ever? I mean, could we ever? So following up on our plea to everybody to donate their plasma, we also know that we are hearing about the fact that antibodies can be created in the lab. So if they can be created in the lab, why is it as important for people to be donating their plasma?
Well, Diana, one of the things I think people have to recognize about human convalescent plasma is when anytime there's been an outbreak, really in the last 100 years like this, and antibody therapy's been used, our first source is actually from recovering human patients, and it's our first best biological shot on goal. Because the companies that say make monoclonal antibodies or make the refined product have to harvest it, they have to go through a process, they then have to get it approved and get it distributed. Where because we are leveraging the blood banking system, where about 30,000 blood donations a day are given in normal times, we had that infrastructure already sort of working. And in terms of the high-tech biotech things like monoclonal antibodies, those are considered drugs and have to go through a safety approval process and so forth. Where what we're using is essentially something that I use as an anesthesiologist when I do clinical medicine, fresh frozen plasma. We're just using fresh frozen plasma from survivors with a lot of antibodies in the fresh frozen plasma.
So the titer level does matter.
What's that, Dinah?
So the titer level does matter.
And we don't know exactly how that relates, but we're trying to understand that more and hope to have more results on that soon as we understand what titer people need and learn more about the specific antibodies.
Right, I've been hearing about neutralizing antibodies.
Yeah, there's neutralizing. So what people have to recognize is this is a really complex fluid. And just like we want to have a lot of neutralizing antibodies, but there's different kinds of neutralizing antibodies. There's neutralizing antibodies to different parts of the virus. There's antibodies that turn on other parts of the immune system to really kind of gobble up and do other things to the virus. So it's, you can think of the neutralizing antibodies perhaps as the lead musician in the band. But if you want to play the whole symphony or the whole piece and play it well, you got to have all of them there. So this is what we call a complex redundant system in biology, because if one person's antibodies aren't working that well, they've got to have another way to kind of make up the difference. And as you may have seen, about 5 to 15% of people that are clearly had COVID and have clearly recovered have low antibody levels, but they recovered. So something else must be going on.
And is that where the T cells come in and all of that, or is that more
cellular immunity, some of these other things, or maybe they're making an antibody to a different part of the virus or a different kind of antibody. But what I call the sort of left-handed responders, at least from a research perspective, are very interesting, because we may get new clues about how the immune system works so that we can leverage those later in the pandemic or leverage those just as general knowledge for insights down the road.
That's very interesting. So there's been talk about, using plasma possibly prophylactically, for preventative purposes if we can gather enough plasma, right?
And it's funny. Nail on the head. Enough plasma.
We both used different. You used baking. I always use a cooking analogy when I talk about a hyperhemoglobin, and I describe it as basically taking gallons of plasma and making a sauce reduction, a very with the exact right ingredients.
I want to come to your house for dinner. That's all I got to say.
You're welcome anytime. You are welcome anytime.
But I think that's exactly what you're talking about, Diana. And we're really lucky. If you look at what Dr. von Behring did when he won his Nobel Prize in the early, 1901, I mean, that was very, very primitive. And we've made so much progress as we bring the new tools from biomedical technology to this whole concept. We ought to be able to make it a little bit better. Historically, you need less plasma serum, gamma globulin to prevent than you need to treat historically. Now, who knows if that's the case?
We don't know when it comes to COVID.
Yeah, we don't know. And all of these generalities you can make about passive immunity, that have been shown to work time and time again, with a few exceptions, probably apply to COVID, but you don't know until you actually get in the lab, do the studies, and make the measurements. And that's
Right.
always, so as optimistic as we are, and I always tell people, as a physician, I have to remain optimistic at all times and really look for the silver lining. But as a researcher, we've got to do the studies, we've got to let the statisticians analyze the study, we've got to allow people to critique the studies and say, why didn't you do it this way or that way? Or what happens when the moon is full? So we can really get a handle on our data and provide objective information to the general public.
So what is considered, I know at the beginning, convalescent plasma was really only being used on a compassionate care basis, which means that, so for people who were on their deathbeds, essentially,
correct,
and you were in the middle of organ shutdown, and it was being given as a last chance, and we've seen plenty of situations where it didn't. What is the current thought on when the best time to use it is? And I have a second part to that question before you answer.
Yep.
Some people, a lot of people in this group consider themselves long haulers, people who are experiencing debilitating symptoms on day 110, 120. And I've heard of them now being prescribed convalescent plasma.
So let's take these two at a time. Take these two at a time, or one at a time. So the first is that anytime, and this goes back to the 1918 flu epidemic, anytime there's a pandemic and serum or plasma or passive immunity is used, the first efforts are what we call now rescue or salvage therapy, where you're talking about very sick people and extremists.
Right. In
these prior outbreaks, obviously, until very recently, there were no intensive care units, that sort of thing, no mechanical ventilators. That's all changed, since the 1960s. So there's always this big push for what you would call rescue or salvage therapy. Historically, though, going back to this incredible data on a number of infectious diseases, starting as early as 1913, when a guy named Simon Flexer at the Rockefeller Institute, believe it or not, used serum to treat meningitis, bacterial meningitis in babies. He showed the sooner the better.
For measles and polio and H1N1, SARS, Ebola.
And they especially for respiratory diseases and meningitis, things that typically in the old days killed people quickly, that first couple, 2-3 days was critical. And I think the consensus is emerging in the current era that the insights of my predecessors, my research great-great-grandfathers as doctors, that the insights they generated prior to antibiotics, prior to a lot of vaccinations in the World War I era, the 20s and the 30s, probably still hold. So earlier is probably better. And then
how severe do you have to be, considering that most people are recovering at home and only told to seek medical attention if they can't breathe?
Correct. And that's been one of the issues here. And that's why it's going to be important to do early treatment trials in the emergency department and other things to really find this out. But I think in general, as people get hospitalized, sooner is better than later. And that's true. If I told you, if that would be true if we were talking about cancer, a broken bone, a heart attack. One of the slides I've shown to try to help people understand this is if you look at what's happened in Iraq with our injured soldiers, survival has really improved over the last 15, 20 years since this started. But one of the real big things that helped is when Secretary of Defense Robert Gates looked at transport times from the field to the hospitals. And he said, we've got to get our wounded soldiers and Marines.
It's all about timing.
To get treatment in an hour, what they call the golden hour. So for many things we do in medicine, time is of the essence. And that's probably true with antibody therapy. And as we've run our expanded access program, it appears as if people are getting treated a little bit earlier, and the community is adopting that approach. And that's certainly what we're hearing from treating physicians across the country. And why, you got to ask yourself, why have people been able to go to earlier treatment? Because supply has increased. We now have increased supply.
Thank you, Survivor Corps.
Yeah, exactly. So there's areas where there's some spot shortages, but nothing, or I wouldn't call them shortages, just some allocation going on. But in general, we're doing okay in terms of a supply demand sort of story. Your group, the Orthodox Jewish community in New York City in the Northeast, in Rochester, Minnesota.
Later on.
Rochester, Minnesota, my medical students who work in my lab have repurposed themselves and so forth. So that's what's happened. And really your story as both individuals and groups, we see this repeated over and over again, this sort of community engagement, facilitating things. I know they're doing a great job in Kansas City, for example, as the physicians and the health systems tell survivors, ask survivors to work with their local collection centers to donate.
That's fabulous.
So early treatment. Now the question about long-term survivors, long haulers, a great phrase. So what's different? So if you look at serious infectious diseases, and I had, believe it or not, I was in the ICU about 10 years ago with pneumonia, just regular garden variety pneumonia. And I'm a fit person, exercise every day, and I ran track for the University of Arizona many years ago, and have a swell gym around the corner in my house. But I was pretty wiped out for a long time after that, and that's not atypical after any serious bacterial or disease or viral infectious disease.
Even the extent of what we're seeing, I mean, we're seeing our members are experiencing extreme debilitating.
What happened though here, what's different here is a certain percentage of people who survive a serious infectious disease, Diana, go on to have more prolonged symptoms. And what you don't know, but we have so many people who've been infected now, so it's all coming at once. So 2% of 1,000 is 20 people, but 2% of 1,000,000 is a lot more. So you've just got this large
one out of 3 according to the CDC.
Yeah, but I'm just saying it's one out of 3 of a small number is a still important, but it's just not as many total people. So I think what we have to do is, because we know so little about this, is think about what we know about how people survive from any other infectious disease. So people obviously have to take care of themselves, get rest, and so forth. But one of the things that can amplify it is people feel bad and they become inactive, and you get into this cycle of feeling bad, becoming inactive. And it's nobody's fault, or it's not a bad thing, and it's completely understandable. But you have to do exactly what you guys are doing with your advocacy, is constantly be in the don't permit what I cannot do to interfere with what I can do mindset.
I understand. I understand. I don't mean to interrupt, but I think there might be a discrepancy in the type of symptoms you're talking about and the type of symptoms that I'm talking about. We're talking about profound neurological issues, COVID-induced diabetes, inflammatory issues across
cardiac
strokes, cardiac issues in otherwise 20-year-old marathoners who 4 months can't climb a flight of stairs.
Correct. And so let me tell you a little story about that. There was a man named, so again, this seems very unusual, and it's really tough for the people that are experiencing it. But let me tell you a story about a guy named Chad Carvin, who is an Olympic medalist. Carvin got a viral illness and almost ended up on a heart transplant list. So there have been for years case studies, case series of people. There's this one particular virus called Coxsackie, which is known to affect the heart. Mononucleosis does strange things. There are all sorts of post-viral syndromes that affect certain things. Is it just one continuous downward spiral? Is it a nadir and then do people bounce back? Is it a new, is it kind of a ratchet down and then people stabilize? Nobody knows. The good news is that,
what do you recommend to all of our members who are suffering from this and are going to their doctors and getting, they're being given diagnoses of anxiety?
Yeah, right. They're getting antidepressants, right?
What do they do? What is your recommendation for them?
My recommendation is that we've got to do a little bit better job in doing what you guys have done with your registry to understand what's going on here, with the thing you're doing with the folks at Indiana University. So the first thing you do, if you think about how you generate knowledge in medicine, so you have case observations by physicians and patients. Then you develop registries. Then you can, once you understand the registries, then you can understand, X% of people have these sorts of symptoms. Y% of the people have these sorts of symptoms. Of people who have those symptoms, 20% never recover. 50% recover somewhat. 30%, they're back 6 months later, they're as good as gold. So what we have to do is begin to, and this is what's so important. You talked about, Diana, volunteering, to donate, but volunteering to be in a registry so people get more information. Then,
funny that you should mention that. We just announced this morning. I haven't even gotten to tell you about this. We just announced the next step of Survivor Corps. It's going to be called Recovery Corps in conjunction with Columbia University. Wendy Chung is the lead scientist on it, and it will be a longitudinal study over the course of the year, serologically and symptomatically. So if you're in New go sign up.
Exactly what we need, because then you can find out, what fraction of people change, what the biomarkers associated with those changes are. And then, as one group tried this, another group tried that, somebody else, doing power walking, whatever it is, and I'm just using that as an example. Yeah. So we can begin to start look at clusters of this. And so the thing, and it's horrible to have to say this to people, but they're just going to, we're 6 months into this, right? I remember I was coming back from, I was visiting the German Space Agency in Cologne, Germany at the end of January, doing a review of their program there, where they do a lot of great stuff. And I'm coming back and watching, because there's a lot of traffic from China at the time in the Frankfurt airport. I'm coming back thinking, what's going to happen on the plane ride back, So, but what is that? That's February 1, at the end of January. And I was probably as aware of it as anybody that wasn't an infectious disease specialist. So what is it now? That's 7 months ago. So, the fact that we've got remdesivir, and that seems to be helping. The fact that the vaccine stuff looks pretty good. Vaccines got a lot of ways to go. The fact we have the plasma.
Do you think that we will have it? Do you think that we will definitively have a vaccine?
So here's what I'm hopeful of. And here's what people have to understand. I think we've got some of the top minds in biotech, and we've got, literally more than 100 that are in some form of development. And I think about 30 have moved on to at least beginning of human trials. So they're evoking immune responses, which is really positive. The question is, are you going to get, sometimes there are vaccine candidates that evoke immune responses, but don't necessarily work that well in clinical trials. Sometimes you're golden. Sometimes you get like the yearly flu vaccine where it works sort of, but it's not perfect. So I think there's a couple of issues there. One is picking the right vaccine, but the good news is we've got so many candidates. I think, enough.
You think that one of them is going to come through? You're confident that it's going to work out?
Well, I would guess that, we're going to throw enough research spaghetti at the wall that we're going to have a few stick, which will be good.
I hope
now,
so.
The question is, are they going to be really fantastic, like the measles vaccine, or are they going to be, pretty good, or are they going to be, comme ci, comme ça? So that's the first question. Then there's questions, 1 shot, 2 shot, oral versus a shot. And
right.
then,
Lori Garrett has spoken quite extensively on this recently about how unless it's a one-time intramuscular shot or it's a one-time thing, that there is no practical way to ever have a globally accessible vaccine. Do you agree?
Right. So logistics, Diana, logistics. Then you've got to make the stuff. You've got to, if you have to store it in a -20 freezer versus a -80 freezer, that's a whole different collection of issues. So you've got a large number of logistical issues. So a whole lot of dominoes have to line up perfectly. I think we will have an effective vaccine. Is it going to be highly effective versus just pretty effective? Who knows? Time will tell. And you'll follow on very rapidly with second and third generations after this first wave. So the vaccines will get better. And then there's a collection of logistical issues that, on the one hand, all of us here can get a book tomorrow from Amazon. So it's not like there isn't logistical expertise in the world. On the other hand, it's still very complicated. So I'm
And there
optimistic.
are a lot of people who are skeptical of
Yeah, and
that.
I would say
Because I don't understand that.
yeah, I would say I'm not skeptical. I'm not skeptical that I just think that we need to be realistic about the challenges, have realistic expectations, and
Right.
recognize that in something as complicated as this, with as many steps, we hope we sort of run the table, but we might not run the table. And if we've learned anything in this whole process, wherever you are in the world, even the places that have handled it perfectly, are still having some bounce backs, some second waves, and so forth. And certainly, I think, Diana, what you've learned
Would
in
you call
survivor.
those second waves? Would you call anything yet a full second wave?
Or
Or
a surge, or whatever you want to call it. And I'm talking about other countries, places
right.
where things are ticking up a little bit in
Vietnam, Australia,
yeah,
right?
yeah, exactly. In places where they thought they had it under control. Correct. So surges, second waves, we can look at it a number of ways. But the point is that there's, even in places where they had the perfect social distancing, tremendous social cohesion, a small country, it's still a very, very challenging bug, and
Yeah.
so I think that's the story here is that the logistics and so forth of this and just the planning and getting the dominoes lined up and so forth has been the challenging part. But again, if you look at it kind of writ large, there's a lot of things to be frustrated about. On the other hand, if you look at groups like our academic network that's come together, your network, and other networks that have come together, it does show that people are, that there's a lot of people out there who don't suffer from learned helplessness, and people are taking an active role in trying to get on top of this. And that's really what we can do. I have a weekly newsletter for my team of about 100 people that runs the expanded access program, and they want to quote every week. And I sent them one last week from the great psychiatrist and psychologist Viktor Frankl, the Austrian physician who was a Holocaust survivor. And he constantly pointed out is that you always don't have control of the circumstances you find yourself in, but you do have some control over how you respond.
Exactly.
I think what's so admirable about your group is you guys have decided to respond. And whether it's given plasma,
mobilizing. We are an army.
Mobilizing, whether it's given plasma or whether it's getting involved with these research studies, these registries. You say you've gone from the recovery. What's your second registry?
It's going to be called Recovery Corps, and in conjunction with Columbia University. We're also doing these research projects that which we've shared with your team so that they get out to clinicians.
Super important. I think
it's important. I want everyone to know, guys, for all Survivor Corps members, you answered a poll. We did the study, and the results went to the Mayo Clinic. I sent them to Dr. Joyner.
Yeah, we've taken a look at them.
Colleagues to be disseminated. Your voices are being heard by every participation and all those polls that you fill out, run by Survivor Corps. You are contributing to science by doing that and helping educate the clinicians.
And I could not agree more. And the thing is, as we move, hopefully, from our expanded access program to emergency use authorization, hopefully relatively soon, we'll be in a position, our group's going to be in a position to, because patients will be getting the plasma through a different mechanism, and we won't be having to do informed consent and so forth. So then we're going to be able to start looking at our database. We've already got a couple projects to look at the quality of donated plasma versus how sick people were before, when they actually had the disease. Did they have a mild case? Did they even have a silent case and were found via some sort of screening process? Or were these people who were desperately ill, headed toward the ICU, but nevertheless recovered? So we're trying to understand these things. And in addition, Diana, and this is what really is important here too, for everybody to understand, besides the specific knowledge on COVID-19 recovery, convalescent plasma, and so forth, is we're going to gain a whole lot of general knowledge about infectious disease and how people recover, and that's really, really important as well.
I agree wholeheartedly, and I have to say that having not known much about the science world before this, it's been quite an education. But what I do see happening, which is very heartening, is collaboration and efficiencies happening that are unprecedented. And so that gives me great faith that hopefully that will extend into the future and be one of the benefits that comes out of this
Correct.
disaster. So
I think a better partnership with the general public in terms of just better medical research, engaging people.
Right.
All
so
different
we're
communities.
an educational feedback loop, so that we can give
all
you
these different communities
what you need to know.
Well, and if you think about it, what we're doing here today, if you think about what it would have, again, I'm almost 62 years old, and if you think about what it would have been in cost us or the barriers to us doing some type of a video interview even 10 years ago.
I would not have been able to afford you.
Yeah, 20 years ago, whatever, we would have had to get satellite links and all this other stuff. And now we can get involved in this almost real-time communication. We've been able, if you look at our site, we update our enrollments almost on a daily basis. So we've been able to get the safety data out there again because of this new technology. We've been able to deploy, and I think that's, if you look at what you guys have done in terms of identifying, setting up a website, getting the website linked to the donation pathways, and if you look at how that sort of, for lack of a better word, the people in commerce would call it just in time. That sort of just in time information to get the donations to happen and to connect people. Again, as frustrating and as horrible as this is, again, a silver lining. If we can continue to leverage that approach, Diana, that you guys have pioneered, we have a chance to do a little bit better.
I hope so. I have a question that came out of today's news conference that sort of took me by surprise. They talked about the distribution of, and it was unclear whether they were talking about the Hig product or a vaccine. And when asked how it would be distributed, the answer was through the military. I'm not sure how that. I'm curious if you know whether or not they were referring to the vaccine.
I knew that they were going to have an announcement, but I was busy working away.
Okay.
I was getting texted by people in our network. In fact, my good friend Dr. John Eisenach, who set the program up in the Denver/Colorado area, and also Carrie Probst, another anesthesiologist who she works with John, and then also Dr. Bill Hartman, who's been you might have seen his name in the press, who's been over at University of Wisconsin-Madison. So they were texting me about what was happening from the White House while I'm sitting here trying to get some documents done so we can work on people. So I don't know how it will be distributed and so forth, and what they were talking about. The main thing.
Can you get back to me on that once you've reviewed it? And
yeah, absolutely. I think the main thing is what we've learned here is really, and again, you guys have shown the way, we've tried to show the way. We've had some fruitful interactions with the federal government, FDA and BARDA. And I can't say enough good things about Dr. Mary Homer at BARDA and Dr. Peter Marks and Nicole Verdun at FDA. They've really been facilitators in their whole teams. Celia Witt, another.
I'm not. There's nothing.
Yeah, no. I just want to say.
I was just asking for clarification because it came as a surprise to me that and a concern that it could get in the way of equitable distribution.
No. I think where I was headed with that is every time we've developed some sort of a process and some project management, things have gone pretty well. So if this is just project management, with some of the considerations you're talking about, good. And I think one of the things we're most pleased,
someone needs to be in charge of it.
And the military has significant logistical expertise, as we know. The other thing too, Diana, if you look at our map, we've treated people in all 50 states. I believe there was one that we had in a small state, Puerto Rico, a number of other territories and so forth. 2,700 sites. This has gone to big cities, small towns, underserved areas, all over. About 20% of our patients have been African American, 40% have been Hispanic. Again, reflecting
reflecting how those communities have been really disproportionately hit by this.
Correct. But what I'm saying is that with your help and the supply that we've been able to generate, and then our network and the academic community and so forth, just everybody working together, you're never perfect, but in terms of the distribution to those sorts of people, I think we've done a little better than you would have anticipated at first, and having this sort of product really restricted to the very well-known academic medical centers. So I think and I always like to tell people, if we're in Fort Myers, Florida, Lawton, Oklahoma, Cheyenne, Wyoming, all sorts of places like that.
We on Survivor Corps, just so you know, from the boots on the ground, we're seeing a lot of shortages of plasma in Florida. Last weekend, there was not a single unit of AB plasma to be found in the entire state of Arizona, which we went into your colleagues, who then told us, which I thought was fascinating, that could be used in place of AB. I'm AB, only 4% of people, but A is 40%. But how is that information being given to doctors? Because the clinicians on the ground don't know that.
And again, we're relying on the blood banking infrastructure and the information on our website. We have about 1,200 physicians, or 12,000 physicians who've registered. We try to give people updates, email, and other things if something big happens. In fact, when we sent out 12,000 emails one day, the information security folks wanted to know who we were sending the 12,000 emails to. So we had to work with them because we had to work with them to send them in boluses and so forth. And they were super helpful. I got nothing but good things to say about them, but it was an unusual experience for everybody. And so that sort of thing. And again, so you've just raised a wonderful issue. How do you communicate best practices that change week to week?
Exactly, and
right in a situation like this. Yeah, it's wild, and so that's what we have to keep thinking about. And again, one of the things we've talked about is our program. When our program is done, or when plasma's done, or when the network we've set up, the network you've set up, the network, our interactions are done, or wound down, is this a research
I
volunteer Burning Man? Does it just go away? Or what can we do? By the way. What can we do? What can we do, Diana, to make sure it's not a Burning Man? To take these lessons learned, and to kind of keep. We were talking about cooking and making sauces a minute ago, but how do we keep the pilot light on? How do we keep
that motivation going? Absolutely. I mean,
I have the networking going. And see, the other thing I think that people have, one of the things that, again, with the kind of, for lack of a better word, civilians and citizens have been really helpful with is, I'm a doctor, I take care of patients or have a lab. So I have this constrained set of skills, and you can get to where you're an inch wide and a mile deep, right? Or maybe a little bit more than that. But we've had people from retail, we've had people from the communication industry, we've had people wholesale, we've had people from all walks of life who brought skill sets to this effort and said, well, I'm not a doctor, I'm not a researcher, but here's how we solved a similar problem in my industry, or in my, and
that's going right back to that collaboration, which is fantastic.
And that's what everybody out here listening, all your members have to recognize, is that everybody has a skill set, a perspective. I joke sometimes that if medicine ends, how many physicians could make a living in retail? And the short answer is not very many, right? And so we need people with those sorts of skills. How many people could make a living in advertising? How many people could make a living doing X, Y, and Z? The orthopedic surgeons would be set because they'd all become mechanics and carpenters, construction guys, but the rest of us, what would we do? So I think that to have access to the people with your skill sets, your drive, your passion, has been super duper helpful for us. And that's, again, horrible situation we find ourselves in. But one of the Mayo brothers, our founders, the two people who founded the Mayo Clinic, talked about the union of forces. He said a union of forces was available to really make the world a better place. And so what we've seen here, to quote one of the Mayo brothers, is a union of forces. And how do we keep that going?
Right. Yeah, well, I mean, absolutely. I have already made my appointment to go donate my non-convalescent plasma, because I've maxed out on my convalescent plasma. I'm just waiting for my iron levels to get back up. Right. And I have already, my appointment is made, although I am appealing to the New York Blood Center for them to let AB AB donors take a break
Correct.
and
Good idea.
again, and I think that we're almost there. So we're making progress.
I had been a pretty religious blood donor and kind of fallen off the wagon, but I started donating again just as a reminder. And it's crazy because of my research collaborators, 20, 30% of them are blood bankers. And prior to this, we were working with the Army to understand how to treat people blood loss. And again, for our soldiers, but also that work, related to if somebody was in any sort of civilian trauma as well. So again, so people need to recognize that things that we're going to learn from them about COVID through these programs you've initiated are also going to have more general capability or insight. COVID may help us understand something else down the road.
That's yeah, absolutely. That's fantastic. I'm going to do we only have a few minutes left. I know that you have a hard stop time, and unfortunately we lost a few minutes at the beginning. So I'm going to do a little bit of a lightning round so that we can get questions answered, because we had more than we could spend a week on the phone with you, here with you. We wouldn't get to the end of them. So let's go through these quickly. But there has a lot of our members have been told by their doctor that if they had COVID, that they should not receive the flu shot this year. Dr. Fauci came out yesterday and said, definitely get the flu shot this year, even if you've had COVID. What is your recommendation?
Follow Dr. Fauci's advice.
Thank you very much. Moving on. Okay. The next one is, when I donate my plasma, am I giving away my antibodies? Is it a zero-sum game where I am giving away my own protection?
It's not a zero-sum game, because more importantly, folks who recovered, it looks like are developing some immunity via their T cells or so-called memory cells, and that's what's going to really help you down the road.
That is very, very helpful to know. That is probably the most frequent question I get asked. Right. From the day I started Survivor Corps, while I was in my bedroom in isolation with COVID in March, the most common user-generated poll, I should say, that comes up on our site is blood type. Everybody wants to know about correlation. I will tell you anecdotally from the hundreds of polls that I have sifted through, again, not doing any real data analysis, we have seen nothing. So
if there may be a tiny difference in some blood groups, but it's really down in the statistical noise. And we've looked at it in our huge database. We'll look at it again, and when we're looking at our safety data. And it is not in the signal to noise range. And I think there were some original reports of this, and there's been some additional reports saying, so if blood group or blood type is a risk factor for developing COVID, it's way down the list, way down the list. And again, not barely out of the signal to noise range.
Thank you for answering that. And now we can end those polls, everybody. Thank you very much. Thanks for participating. So let's say I have a family member who is suffering of COVID, and our advice to everybody is, and we send them directly to the Mayo Clinic's expanded access protocol. And it is beautifully laid out with a link for families. This is what show your doctor. Almost everyone who we have sent there has gotten the plasma that they needed. It's worked remarkably efficiently, beautifully. The process, though, so for people who are not as familiar with the Mayo Clinic's expanded access protocol, if you have a loved one in the hospital sick with COVID in the ICU, and you are trying to access plasma, can you just walk people through how you do that? And what are the, if your doctor won't do it, how many times would you get it? How long does it take?
The most important thing is really your physician, the treating physician, or a member of that team needs to register. They need to then begin a process of registering the patient. The patient then has to provide informed consent. That's normally, you sign a document, but everybody recognizes in the current environment, this is going to be challenging. So we have various ways to do informed consent. And then really, that's our job. And then the blood bankers supply the convalescent plasma to the hospital. It's administered. And we started with only 1 unit per patient, but now you can do multiple units. And then
is that advised, or is that just dependent on the person's situation?
It depends on the treating physician. We've really let it at the discretion of the treating physician, and also probably availability, Dinah. Then then we asked for a 4-hour report to make sure there was not an immediate serious adverse event. Then we asked people to fill out some forms 7 days later to let us know how things are going, so we can begin to understand if our treatment worked, if it was safe, if there were other strange things that happened. And that's really the process as it is. As we've moved into these surge areas that are super busy in the South, we've reduced some of the questions. Our questionnaires that we ask the physicians are simpler, so we can just get very, very high level, better, worse, ICU, not ICU sorts of questions. And we're trying to make it as simple as possible. When we stop enrolling and as approval moves to a different mechanism, we will then be in a position to we have a ton of back-end work to just do the curation of all this data, the data mining, looking for missing records, getting in with all HIPAA, all privacy stuff respected, just trying to understand the outcomes. But that's going to be, a 6 to 9 month project after this.
2 last questions. One is a simple yes or no. You're free to expand if you want. Has there been a scientifically documented case of reinfection?
Not that I am aware of.
Thank you. Last question. Andy Cohen spoke out yesterday about the prohibition on gay men donating plasma. We know that the incubation period for HIV is 7 to 10 days. I know that the FDA has relaxed those regulations, but what is being done to push it towards knowing this desperate need that we have? And, we keep on saying we don't want to leave a single survivor behind, but why is that not based on risk-based behavior as opposed to identity? And why are we not reviewing other things like people who did their junior year abroad in England in 1985? Because if I was on my deathbed, I'd rather take the chance that I had a 40-year incubation period for mad cow and get that plasma than face it.
As somebody who's not, responsible for the regulations,
no, I'm just interested.
Blood banking is a appropriately highly regulated field.
Yes.
Those regulations, at least when they're initiated, are initiated for a reason. And what needs to happen is those reasons need to be evaluated and in the context of new technology and other things from time to time. And I think that the regulatory bodies need to get engaged, and I'm sure I know they are, to figure out how to do exactly what you described. And even when they move extremely fast for them, it's probably not fast enough for some people.
Not fast enough.
For some people, yeah, correct. And so, what I mean, telling people to be patient and so forth is kind of patronizing. But medicine is a highly, highly regulated field. And
no, I understand, but they were able to relax it at the beginning of the pandemic. Right. And so they are fully capable. And now that we have an official national push for plasma, it seems that the most sensible thing, if we do not want to leave a single survivor behind, is to have those rules based on science, not on outdated.
Just outdated reactive regulation from 30, 40 years ago. Yes, right. And I think that the people who make the regulations are aware of this. They're trying to work their way through them. And I think one of the, again, a silver lining from a difficult situation like this is people relook at things. And so hopefully that'll happen, in a timely fashion. Because I agree. We don't want to leave anybody behind.
Yeah, and I do hope that is one of them in all of this.
Well, and I think one of the things, that we've again, I mentioned it earlier, that we're and I hate to use the word pleased, But one of the things we note about the EAP is that we've really tried to be as inclusive as possible, geographically, economically, ethnically.
Yes.
And so we want to we really want to continue to push for that sort of inclusive. I mean, we had to make provisions for prisoners to be treated. Yesterday, we got an email from Florida about could one of the hospital systems down there work with us to translate our consent forms into Haitian Creole. So
Right.
again, I mean, it's a horrible situation, but we're really
But hopefully
very
some
proud when people reach out to us with those sorts of requests, and we can be an advocate.
Good. Well, let's be advocates together, Dr. Joyner.
Always.
Always. I
And
cannot
remember everybody here, and I want to thank everybody here for living one of my really big maxims, which is don't permit what you cannot do to interfere with what you can do. And you folks are showing what you can do.
Thank you. Thank you. You are an inspiration. Our lives are in your hand. We trust you.
We do. And we'll come back and visit. You know, hopefully we can visit in a month or two. Okay, Diana, and by then, you know, I'll have had a chance to. The lactic acid in my brain will be a little bit lower, and I'll have a chance to get some sort of a cruise state as opposed to, you know, above my red line.
Well, who knows what the world is going to look like in a month from now.
And you don't, you just figure out what's in front of you.
Exactly. So it's a date. And thank you very much.
Well, thank you so much. Thank all the folks out there watching, the medical community, our network, the country, really the world, because this information is useful everywhere. Really, really appreciates what you've done. And literally, we could not do what we've done. And the announcement we heard today would not have occurred if it had not been for you. So
well,
thanks.
That's pretty incredible. That is, yep. I'm gonna call a mic drop on that one. Okay.
Okay, there you go.